Good day, my dear friends. Welcome back with a new group from 5 practical cases. So let's get started. As usual, I introduce the case with clinical presentations and give chance to know the type of exam. And after 10-second intervals, you can describe the finding and suspected differential diagnosing and final diagnosis. After that, I will make discussion and explanation, then answer and final diagnosis. Case 1. This is a 40-year-old woman with sudden left limb monoparesis and hyporeflexia. This is 2 exam. This is our MRI images, and MRI the bone appeared dark like this. This is calvarial bone, and subcutaneous fat appeared bright. So this is white matter, which also white. So this is a T1 weighted image. If you look, there are contrast in the choroid plexus and contrast in the sinuses, as well as contrast in the superficial vessels. And there are lesions here which showing contrast enhancement in the marginal pattern. And this one is a cervical spine with contrast also, and this part is the cord which is showing also lesion here which is taking contrast. So there are enhancing lesions in the white matter of the brain at that region, which is representing the genu of the corpus callosum, and this one is the left lateral aspect of the cervical cord. So let's get to the next slide to discuss the case. This slide showing the 3 sequence here. This is the 2 sequence which already showed in the previous slide. And this sequence, the white matter appearing darker than the gray matter, and the CSF is dark also. So this is FLAIR image. So FLAIR image with enhancing study T1 and enhancing cervical T1, showing enhancing lesions and other lesions which appearing in the regions of the white matter also, like this lesion, and the lesions in the corpus callosum here. So the key words here, if there are multiple lesions arranged in the paraventricular region and making dorsal finger appearance, or if there are callosal-septal interface like this callosal regions involvement, and in the post-contrast study, if there are incomplete ring enhancement like this, there are defect of enhancement at that region. So all these features, also the involvement of the cervical spine, cervical cord here of the lesion. If there are also all these lesions are representing demyelinating disease, most likely representing multiple sclerosis. You need one laboratory test which is called oligoclonal band of IgG are demonstrated in the cerebrospinal fluid samples to confirm the diagnosis. So the final diagnosis for these lesions enhancing incomplete ring enhancement with involvement of the cervical also, and appearing in this coronal imaging in the perpendicular to the ventricles like this. So the final diagnosis here is multiple sclerosis or MS. And now case 2. This was a 60-year-old man presented with severe chest pain, and this is a study which done to him. After 10 seconds I will discuss the type of the study. Only to be familiar with the nuclear medicine study, I presented these cases. This is a case of cardiac imaging, which is called the cardiac SPECT or cardiac stress SPECT image for this man who complained from chest pain. If you look, there are two rows. When you find there are two rows like this, so the first row always representing the stress image, and the second row is representing the rest image, which done after 2 days later, usually in that study. I will explain in details in the next study. Next slides also about the type of the tracer and like this. Before I go into the tracer type, I want to talk about the supply for the myocardial wall and the divisions of the myocardial wall. If you look in the short axis view of the left ventricle, so you suspect this is the myocardium. This wall is the anterior wall and this wall is the inferior wall. However, there are septal wall here and there are lateral wall. So septal, lateral, anterior and inferior. The anterior wall usually supplies by the left anterior descending artery or lead. Left anterior descending artery also supplying the anteroseptal aspect of the septal wall like this too. So this is the basal segment of the myocardium, the mid segment of the left ventricle, also divided into 6 segments like this, and the apical segment dividing into 4 segments. The right coronary artery usually supplying the inferior wall and also supplying the infroseptal aspect of the septal wall. So infroseptal aspect and inferior wall, red one, supplied by the RCA or right coronary artery. At the apical regions or level, the inferior wall only is supplied by the right coronary artery, and the septal wall at the apex is supplied by the lead. What about the lateral wall? Lateral wall is supplied by the left circumflex artery, and the left circumflex artery supplying these regions. As you see, also lateral wall can be divided into anterolateral and infrolateral. So this is the regions in the short axis of the myocardial imaging to know which vessel supplying which wall or of the myocardium. Now we return again to our case. This is our case. So this view, if you look to the heart and can you see the 4 walls like this? This is a septal wall because it's separating the left ventricle from the right ventricle. So this one is the septal wall, and the other one is the lateral. This one is the anterior wall and this one is the inferior wall. And if you look at the 4 walls and you can find it like this, it is called the short axis view of the myocardium. However, this one, when you find the myocardial in the 2 views only, anterior wall and inferior wall, so this is which is called the vertical long axis. And also this is the apex in the vertical long axis. However, when arranged like this, the myocardium, this is the horizontal long axis. And the apex at that time is at the superior or upper part of the film. And this is the septal wall, as you see the other ventricle here, and this is the lateral wall. However, here you can see the anterior wall and the inferior wall. The 4 walls, anterior, inferior, septal, and lateral, can be seen in the short axis. So this is the axis which take in the tracer. What about the tracer? The tracer used here can be used in the which is called the technetium 99M tetraphosmine. This one, tetraphosmine, can be given as the stress image as the first row. All the first row is stress image after 45 minutes from injection of the tracer. After 2 days, you can take the rest image as we seen here in the second row, or in the all imaging in short axis, vertical long axis, horizontal long axis. In the second row here representing the rest image which is taken after 2 days. So what is the difference between the two images taken in the stress and taken in the rest? If you look closely to this wall, you can see this defect. This defect in the anterior wall and anteroseptal wall, representing a defect in the stress image. Also, if you look at the vertical long axis, you can see the defect comparing with this normal perfusion of the inferior wall. So there are defects in the apex and the anterior wall and the anterior septal wall. Also, you can see here at the apex, we can see in the horizontal long axis, there are defects. After 2 days, in the rest image, this defect is disappear, and now there are normal perfusions of the all myocardial wall. So normal perfusion in the rest, however, defect only in the stress image. This is the keywords. If there are decreased perfusion in the stress image and normal perfusion in the rest image, it representing reversible perfusion defect, and according to this site is the anterior and anteroseptal wall and the apex of the heart. So if the defect is reversible, as we see here, become normal in the rest image, so it representing myocardial ischemia, not myocardial infarction. So the final diagnosis of this case, there are defect in the anterior wall which returning after 2 days in the rest image. This is the short axis and this is vertical long axis view. Anterior and the apex are supplied by the lead, which is called left anterior descending artery, and the disease is the ischemia, not infarction. So the final diagnosis is lead myocardial ischemia. And now case 3. This is a frontal chest radiograph in 34-year-old man presented with radicular thoracic pain involving the left hemithorax from spine to sternum. What is the abnormality in the frontal chest radiograph? If you look closely to the frontal chest radiograph, you can see the trachea which appeared central, and the heart border which appearing not saluting, and the average size comparing with the thoracic width. The lung itself in the right side, the comparing upper and middle lower zones, there are no focal lesions or abnormal hypertransregency. And the examined clavicles and ribs appeared normal. The hilar regions in both sides are symmetrical and there are no hilar masses detected, no pleural effusions, the costophrenic angles appeared normal, and no pneumothorax. However, there are an abnormality here in the left paramediastinal region in this frontal chest radiograph. This opacity, which appearing here, is the abnormal opacity and not should be appear because this is the aortic arch, and this is the regions of the bay of the pulmonary regions, and this is the wall of the left ventricle. However, this abnormality in the upper mediastinal regions is the abnormal opacity appearing to passing or traversing the clavicle, as we see here, this extension, and not communicating with the cervix. This sign is called the cervicothoracic sign. Cervicothoracic signs can be negative, like this, our case, cervicothoracic sign, negative due to not continuous with the neck regions and also crossing the clavicle. As you see, this is the left clavicle and this is the mass which crossing the clavicle. If the mass is crossing the clavicle, is representing posterior mediastinal mass, not anterior mediastinal mass. So, if the mass crossing the clavicle, like this diagram, which is showing a mass here 1, which cannot cross the clavicle. However, this mass 2 can cross the clavicle. So, if the mass is crossing the clavicle, so this is this is the region of the clavicle representing posterior mediastinal mass. Because the lung appearing like this, so the posterior region only can appearing crossing the clavicle in the frontal view. However, if the lesion is anterior mediastinal, cannot be cross the clavicle because the anterior mediastinal finishing here before underwent the clavicle. So if you look to this another patient only for comparison, you can see the silhouetting here of the upper border of the lesion. There are opacity appearing here and appearing there, and this opacity is continuous with the cervix, so it is called positive cervicothoracic sign. And also you can define the upper border of the lesions above the clavicle, so this lesion is the anteromediastinal lesion. So if the lesions is continuous with the cervix and you can't define the border above the clavicle like this one, so this is anteromediastinal mass. Actually, this one is a goiter, extension of the thyroid mass from the thyroid gland to the anteromediastinum. So this is which is called cervicothoracic sign. Okay, we want to return again to our lesion, this lesion, which appearing in the left paramediastinum and crossing the clavicle and not continuous with the cervical region. So this is which is called the negative cervicothoracic sign. Negative cervicothoracic sign representing an posterior mediastinal mass. And the CT for the same patient, this is the sagittary formatting imaging post contrast. This is the aorta and descending aorta, and this is the heart, and this is the mass which appeared in the posterior mediastinum near the spine. Axial image also confirming the site of the lesions as it appearing posterior mediastinum near the spine and posterior to the trachea. So this is the posterior mediastinal mass. Okay, from the chest X-ray you can define these lesions as a posterior mediastinal mass. What is the differential diagnosis of the posterior mediastinal mass? Neurogenic tumors coming in the top of the differential diagnosis in adult patient. If the patient is young, also neurocyst or neurocele, meningocele can be considered as a differential diagnosis. Hernia is the second most common posterior mediastinal mass if the posterior mediastinal mass is lower in the cuts near the abdomen, like buctalic hernia or sliding hernia, hiatus hernia, or like this. Lymph nodes enlargement due to any cause can be considered as a cause for the posterior mediastinum. However, it occurring in the anterior mediastinum more common than posterior mediastinum. Lymph nodes enlargement can be due to metastatic inflammatory process, infectious like TB, sarcoidosis, or like this. Extramedullary hematopoiesis, this is also differential diagnosis for the posterior mediastinal mass in the patient who have any hematological disorders. Forget duplication cyst like neurogenic cyst, bronchogenic cyst, or esophageal duplication cyst can be also considered as a cause for the posterior mediastinal mass. So the differential diagnosis on the top of differential, neurogenic tumors and hernia and other causes. So the final diagnosis for this frontal chest radiograph pathology which appearing here is neurofibroma, posterior mediastinal mass, and it was a case of neurofibroma in patient known case of NF1. Case 4 to be continued the next Wednesday. Only I put the image. This is an MRI image, and this is the urinary bladder, and this is the uterus. And the answer I will be give in the next Wednesday presentation. Case 5 also. This is a pelvic X-ray, and also to be continued the answer in next Wednesday with clinical presentation. Good luck and have a nice day.